We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. Electrolytes and electrolytes often is some situation where everybody gets confused. And there are some people who hate electrolytes and some people who hate it badly. So I've hardly met somebody who really likes electrolytes in that regard. So we'll try to cover some important aspects of electrolytes. You need to understand a bit about homeostasis. So when you talk about the level of sodium in the body, you have to look at the tonicity and the volume. So sodium level will not only depend upon its own level, it will also depend upon the water level. So if you have hyponatremia, it may be because of little sodium or more water. What is more important, water or sodium? It's actually the free water. Most hyponatremia is because of a high level of free water. Now, water is conserved using 2 mechanisms, thirst and urine. So thirst, how much water you drink, and how much you excrete. These are the two parameters which really decide from that perspective. And from the brain, you have got the organum vasculosum, lamina terminalis, and subfunicular organ which control that, and they secrete a very important hormone called arginine vasopressin, which basically is responsible for the retention of water. So if you're getting dehydrated, vasopressin will come up and it will conserve your water coming from the urine, and your volume goes down. The renin, angiotensin, aldosterone system gets activated. And this system basically causes increased loss of potassium. So if you have RAS excess, you will have hypokalemia. If you have RAS deficiency, you will have hyponatremia with hyperkalemia. Now, there is a third player, which is atrial natriuretic peptide, which is causing the loss of sodium in that regard. So this becomes very, very important. And potassium, as we know, is largely an intracellular ion, which is regulated from that perspective. If you give somebody a beta agonist, you will cause pushing of the potassium inside. Serum sodium can be done any time of the day, but remember that do not do it after strenuous exercise. You may have falsely high level of sodium. After a seizure also, the sodium levels may be high. You may have falsely low level in the setting of deficiency of protein, lipids, and glucose excess, and high levels in hypoalbuminemia. Normal range is 135 to 145. We are worried about levels less than 130 and above 150. Potassium should be done any time of the day. The caution is avoid hemolysis and syringe, no tourniquet or standing sample. Levels may be falsely high in hemolysis. So I said phosphorus, potassium, magnesium, do not use tourniquet, and low with high counts, the levels may be low. For blood gas analyzer, the value is typically down by around 0.4. So again, take it with a pinch of salt in that regards. Very importantly, there is a close interplay between sodium and potassium. If your sodium is high, generally potassium is low. If your sodium is low, your potassium is high. So high sodium, low potassium means excess of the renin, angiotensin, aldosterone system. If you have hyponatremia and hyperkalemia, is a problem in the renin, angiotensin, aldosterone system. But what about condition of high sodium and high potassium? Anybody? That means you are retaining both sodium and potassium. The classical example is Gordon syndrome. On the other hand, if you have low sodium and low potassium, it means you're losing both either in the intestine or using the kidney. So Bartter, Gitelman, tubulopathy, diuretic use, that is the classical cause of hyponatremia with hypokalemia. So hypokalemia is the most important, so we'll talk that. It can be because of excess free water, which will be U, or hypervolemic with low levels of uric acid, or a sodium loss where you're losing sodium, where you will lose volume. You will be hypovolemic with high uric acid. Excess free water can be overload, cardiac, liver, or renal. Here your urinary sodium should be less than 25. Anybody with hyponatremia should have a urinary sodium less than 25. High urinary sodium means the urinary loss. While if your free water loss is reduced because of SIADH, cortisol deficiency, or hypothyroidism, it may be there. Remember, SIADH is a diagnosis of exclusion. Always look for cortisol deficiency and hypothyroidism. Sodium loss can be extra-renal, where your urinary loss will be less, or renal, where your urinary loss will be more because of a tubular problem or a RAS defect. And here the urinary sodium will give you a clue. So the most important test to look at is uric acid. Uric acid is a marker of fluid status. High volume, high urinary loss of uric acid, low uric acid. High uric acid means that you have got volume depletion. Urinary sodium, as I said, if it's more than 25, it really indicates that you're losing sodium in the urine. And if potassium is high, hyponatremia with hyperkalemia means salt wasting in that scenario. So the approach is look at volume. Too much volume, fluid overload. If volume is normal, get a thyroid cortisol normal. This is SIADH. If it's hypovolemia with a low urinary sodium, it is GI loss. High sodium, you look at potassium to classify into tubulopathy or RAS defect. So again, very basic things: volume, urine sodium, and potassium. I'm not talking about any very costly investigation like renin or aldosterone at the moment. These will give you a clue. So we'll start off with the cases, please, Dr. Dhwani.
Thank you, sir. And the first case that we have here is a 12-year-old boy with diabetic ketoacidosis. He has high sugars with hyponatremia, normal potassium, and a metabolic acidosis. So my question is to Pradeep, sir. Do you think we need to do something for this hyponatremia or
Okay, so as we have been through the review of hyponatremia, what we have seen, whenever you have sodium, always correlated with sugar, potassium, this protein, lipids, etc. What we see here, this is a patient of DKA where there is sugar very, very high. So we have to convert and we have to see the corrected sodium. What is the value of corrected sodium? So generally, okay. So generally, what we do, we calculate with this common formula: sodium plus blood sugar minus 100 into 1.6 upon 100 into 1.6. Commonly, we use 1.8 for every 100
yes.
milligram of sugar which is raised. So applying that, it will come approximately 136 milliequivalent per liter. Which is normal for this patient. So this is clearly a case of pseudo hyponatremia.
Thank you, sir. So, as rightly pointed out, hyperglycemia can falsely decrease your serum sodium levels, and you need to correct it to get the right sodium value. If your corrected sodium is in the normal range, you need not intervene in such patients. The second case is a 1-week-old child who was brought with complaints of lethargy and was found to have hyponatremia with normal potassium. So I would like to ask Jyoti ma'am, how would you like to approach this child?
First of all, we have to see if there is dehydration or not, because there is hyponatremia with normal potassium level. So what is the hydration status of the child?
The hydration status was normal in this child.
So seeing on to the algorithm fluid status when there is euvolemia, so we have to see for the blood sugar levels, we have to see for the thyroid and the cortisol level.
Now that we see that the child has a ketotic hypoglycemia, what diagnosis do you have in mind of a child with ketotic hypoglycemia and hyponatremia? What finding, if this was a boy, on clinical examination would point to the diagnosis here?
So we have to see for the micropenis and other midline defect to come to the diagnosis.
So very well pointed out by ma'am. Euvolemic child with mild hyponatremia and a ketotic hypoglycemia points towards a cortisol deficiency. And as we know, in a euvolemic child, you think of SIADH, but it is a diagnosis of exclusion. So before you jump to that conclusion, you carefully examine the child. And this micropenis points towards the pathology of MPHD, multiple pituitary hormone deficiency, wherein the child will have hyponatremia and ketotic hypoglycemia. So in this child, during hypoglycemia, cortisol and growth hormone levels were done, which were subpar for the level of hypoglycemia. Moving on, the next case is a 14-year-old boy who presented with drowsiness and a more severe degree of hyponatremia, that is 116 millimoles per liter. Clinically, he is euvolemic, has urinary sodium of 100, urinary osmolality of 300. So dilute blood, concentrated urine, the diagnosis of SIDH was considered, and the child fluid restriction was done for the child. Do you agree with this diagnosis, sir?
Actually, the picture is looking like a side ADH only, but as you already told that it is diagnosis of exclusion. So first, because it is euvolemia, we will first see cortisol and thyroid level, and if they are normal, then we'll diagnose SIADH. So as we see in the values, thyroid is low, free T4 is 2, which is low, cortisol is also low for this 120. So it is the we will diagnose it as multiple pituitary hormone deficiency, not SIADH.
Very well pointed out. So if in the setting of hyponatremia, when your sodium is 116, your cortisol should be more than 550. If in that setting, your cortisol is less than 550, you need to think of an underlying cortisol deficiency. And when you have a isolated cortisol deficiency is usually unlikely. So in that setting, you can also look for other pituitary hormone involvement. Like we see here that thyroid levels were also low. So we have an algorithm that we've developed for evaluation of children with hyponatremia, and you can definitely check out our app and use it in your clinical practice. Next is a 3-week-old child with failure to thrive. Again, very low sodium, 110 millimoles per liter. Had a birth weight of 2,500 grams and at 3 weeks has gained only 100 grams. The neonate is clinically dehydrated with a PCV of 62, has elevated urine sodium of 100 millimoles per liter. The catch here is the child has a serum potassium level of 8.4. So my question is to Dr. Tarun sir, what all differentials would you consider in a 3-week-old neonate coming with hyponatremia, hyperkalemia, and an increased urinary sodium?
So it is a clear case of we will go for the fluid status, as well as we know that the child has only gained 100 gram since 3 weeks. So it is clearly evident in PCV also the child is dehydrated. So my next step here will be to looking at the urinary sodium, which is clearly more than 30 millimoles per liter in this child, which is 100 millimoles. And then we go for the potassium in this. If potassium is low, we have obvious a single reason of tubulopathies or the use of external drugs like diuretics or other things. But here the high potassium indicates either it is a RAS defect or aldosterone deficiencies, as well as this is a picture of genitalia of the child.
Yes.
So it is a DSD with bifid scrotum, I think, and with empty testis, no testis there, and probably the clitoral hypertrophy. So this is a congenital adrenal hyperplasia. So the most common which presents with at an early age of this 3 weeks, so could be a 21 OSD defect. So in this cases, high 17 OHP levels clearly indicate this is a CH.
Very rightly pointed out, sir. So in around 3 to 4 weeks, if you have a baby coming to you with hyponatremia, hyperkalemia, appears dehydrated, look at the genitalia. If it's a female, if it's actually an XX karyotype, you will see empty scrotal sacs with clitoromegaly, or which may also appear male genital-like. However, if it is a male, it is often missed out because the genital may be normal. But if you have hyponatremia, hyperkalemia in a 3 to 4 week child coming with dehydration, think of CAH, get 17 OHP levels done, which may help you clinch the diagnosis in such patients. So as sir has rightly pointed out, 17 OHP levels were high, and this was actually an XX DSD presenting with salt wasting crisis. Next, we have a 6-month-old girl who was diagnosed with cystic fibrosis in view of the fact that she had failure to thrive and had recurrent chest infections. She also had high sweat chloride levels, and on the basis of which she was treated on the lines of cystic fibrosis. However, she had no steatorrhea, suggesting that there was no exocrine pancreatic insufficiency. When she came to us, she presented with a salt wasting crisis, and what we found on evaluation was hyponatremia and hyperkalemia. So I would like to ask Dr. Pradeep, do you agree with the presence of hyponatremia with hyperkalemia in a child with cystic fibrosis, or should we consider an alternate diagnosis here?
Okay, so in this infant, we clearly see that in spite of having recurrent chest infection and high sweat chloride, but there is no signs of exocrine failure in terms of no steatorrhea, and there is hyponatremia and hyperkalemia. So naturally, for the algorithm of hyponatremia, we should know the next, what is the volume status of the patient. So volume is, I think, dehydrated. So next we have to see what is the urinary sodium excretion, and then potassium, serum potassium. So urinary sodium excretion is, I think it is more. So we should consider
Yeah, so
yes,
the child is losing salt in
salt.
Yes, so this is hyponatremia.
Hyponatremia.
The baby is losing salt in urine despite having hyponatremia and has very high renin and aldosterone levels despite hyponatremia.
So yes, so normally there should have been we should have considered RAS defect, but what we are seeing here, The both are high. So resistant should be maybe the resistant of this tubular receptors resistant can be there. So we can go for further, yes. So ENaC, epithelial sodium channel receptor resistance might be there, which can present as pseudo hypoaldosteronism type 1.
Yes, sir. Thank you. Very well pointed out.
So I think a very important message, if you have hyponatremia and hyperkalemia, that is a very, very lethal combination. This child will go into crisis, may die also. So if you have hyponatremia and hyperkalemia, immediate evaluation and management is required. Most common cause is 21-hydroxylase deficiency. Look at genitalia. If it's abnormal, you get the diagnosis. But remember, males may have no clinical features. So you may miss the diagnosis there. And then if you have excluded that, then go for pseudo-hypoaldosteronism. They are often misdiagnosed as cystic fibrosis. Why, Dhwani?
Because the clinical presentation is very similar. They are hypovolemic. Their chest secretions are stickier. So,
and I remember this girl was admitted in the ICU a couple of times because they develop a lot of inspissated secretion and they become really pneumonia and become very, very difficult. Even mild infections become severe in these scenarios. Tarun had managed this girl a couple of times in the ICU. So this is an important scenario to look at. But we expect what will be the potassium in cystic fibrosis?
Cystic fibrosis will classically have hyponatremia, hypokalemia, hypochloremia, all low.
So this will be really against this scenario.
Sorry. Moving on, we have a 1-month-old child who was brought with complaints of reduced feeding, had a birth weight of 3,100 grams and now only weighs 3,200 grams. So that's poor weight gain. Has hyponatremia with hyperkalemia. The first diagnosis that we thought of was CAH. So we went ahead with 17 OHP levels. However, the levels were normal, but the cortisol levels that were done showed elevated 1,200 nanomoles per liter, which is an appropriate response in the setting of hyponatremia. The next, we went ahead with renin aldosterone levels, and they were both again on the elevated levels. So my question is to Jyoti ma'am. Now, this child appears very similar to what Pradeep sir's case was. So, but however, this baby does not have any chest infections so far. So what will you think of the diagnosis in a neonate presenting with such complaints?
So 1-month-old boy presenting with failure to thrive, with hyponatremia, with hyperkalemia. First, we have to rule out 21-hydroxylase deficiency, CAH we have to see. Since 17 OHP is normal, then we have to see for the cortisol axis. That is normal. It's normal response to the hyponatremia. Then we have to see for the renin aldosterone. We have to see for the aldosterone axis. So aldosterone is 200 nanogram per deciliter. In such case, we have to see for the transient pseudo hypoaldosteronism. So in that case, we have to see for the urine REME, and we have to go for the renal imaging to differentiate it from other hypoaldosteronism. So in this, so what is the urine REME and?
Yes, so ma'am, as you rightly pointed out, the urine routine showed evidence of infection with more than 100 pus cells.
And we have to go for the USC where, okay, there is
Sure.
obstruction. So this is the case of transient hypoaldosteronism.
Yes, thank you so much, ma'am. So again, as ma'am very well pointed out, so in a child, 1-month-old neonate presenting to you with hyponatremia, hyperkalemia, you will always want to rule out CAH. When you get normal 17 OHP levels with high cortisol, you know that the glucocorticoid axis is preserved. So we went ahead with to look at the mineralocorticoid axis. Now we see that both aldosterone and plasma renin levels are elevated. So this scenario is very similar to the previous case where we have an aldosterone resistance. However, before we think of a genetic diagnosis, especially in a neonate, we need to rule out a cacat abnormality or a urinary tract infection before we label these children as hypoaldosteronism, because in these children, the pseudo-hypoaldosteronism will be transient and they will recover with treatment of infection. Over to sir.
I did based upon your sodium level and the duration. And this is very, very important because you can have a lot of problems if you treat it inappropriately. So the duration is less than 48 hours, which is acute hyponatremia. and there are symptoms like seizures and sodium is very low, then you give 3% saline, which will be there to correct the sodium level in this perspective. If, however, you have mild to moderate symptoms, 120 to 130 with symptoms, you can then give a small dose of sodium chloride. Do not give high doses of hypertonic saline because that can cause cerebral problems and that can be really difficult. If it's above 48 hours, go for symptoms, and symptoms are severe, you can give a course of 3% saline. If they are mild symptoms, don't give 3% saline. This is a big message, that do not give 3% saline in the absence of acute symptomatic hyponatremia. Otherwise, the child is going to have a lot of problems and they will go into a brain injury. So hyponatremic dehydration, we correct based upon dehydration level. We look at how much is the sodium deficit, how much is the isotonic sodium deficit, what is the maintenance requirement, what is the correction dose, and how much fluid has been received, and then we calculate that. Usually, you will be able to have a good enough volume, and this is calculations already provided, and we have developed applications to identify. In general, you don't want a very, very high level of sodium. You will maybe have a normal saline or a half normal, which will do the trick. So in this case, it turned out to be 90 millimole sodium at 65 ml per hour. Coming on to the second scenario of hypernatremia, it can be because of reduced free water, which is because of decreased intake, but mostly because of increased loss, because of extra-renal or renal problems like diabetes insipidus. So hypernatremia chronic can be because of diabetes insipidus or a sodium load, which can be endogenous or exogenous. Most common cause, as I said, is because of a free water problem and not because of a sodium overload. So if you have a child with hypernatremia, look at salt load, mannitol, and diabetes. If it's not there, go for urinary osmolality less than 600. This is diabetes insipidus. Check for vasopressin response, present central DI, absent it is nephrogenic DI. If on the other hand, urinary osmolality is high, concentrated blood, concentrated urine, look at urinary sodium. If it's less than 25, this is GI loss. More than 25, this is sodium load. So we'll start with the first case, 3-month-old girl with altered sensorium. And Dr. Dhwani.
Thank you, sir. So we have a 3-month-old girl with altered sensorium, has a sodium of 170 with normal potassium. The urine osmolality is 100 milliosmoles per kg. And this child was, because in view of concentrated blood and dilute urine, was advised water deprivation test. So my question is to Dr. Nitin, sir, do you agree with this step?
Actually, for diagnosis of diabetes insipidus, this is the gold standard test. But when diagnostic criteria is already met, so we don't have to do this test. As the criteria is that if sodium is more than 145 and urine osmolality is less than 600, then it is diagnostic of diabetes insipidus. So we'll directly give the vasopressin to see it is central or nephrogenic.
Absolutely,
Right.
sir. And in fact,
Mm.
doing a water deprivation resulted in precipitation of seizures and did more harm. And so in such scenarios, as sir has mentioned, where you meet the clinical criteria, you can go ahead with the AVP response test directly.
Yeah. And response was positive, so it is central. Okay.
Next, we have a 14-day-old girl with failure to thrive. The birth weight was 2,600 grams and now she weighs 2,300 grams. She was exclusively breastfed by a primary gravida mother and her serum sodium was found to be 182 millimoles per liter with extremely high urine osmolarity of 1,000 milliosmoles per kg. So my question is to Dr. Tarun. How do we explain this condition? If we are losing sodium in urine, why is it still high? What is going wrong with this child?
So this is a failure to thrive, not gaining weight, exclusively breastfed, high sodium, urine osmolality. So probably some external sodium load is being given to the child. So we look for urinary sodium in this patient. So if urinary sodium is more than 30 or less than 30, if more than 30, that means it's a clear sodium load. And with a high urinary sodium in this child of 110 millimoles and urine osmolality of very high. So probably this is a primary gravida mother, which is a lethal condition in newborns, in which breast milk related hypernatremia is there, in which due to decreased amount of intake of the breast milk, as well as the decreased production of the breast milk, the child intake is low, and the child gets severely dehydrated. In these kids, we don't assess the dehydration level because the skin is doughy to touch, and the child is not so lethargic because of hypernatremia, a good vascular volume in the kids. So probably it's a breast milk related hypernatremia.
Yes, so very well pointed out. So especially in the setting of a primary gravida mother, if there is difficulty in feeding or an inadequate expression of breast milk, the babies develop hypernatremia due to reduced fluid intake and not per se because of an increased sodium load. Next, we have a 13-year-old boy with encephalitis. The child is on ventilator and suddenly has developed polyuria at 10 ml per kg per hour. So I would like to ask Pradeep sir, what will you think of in this condition? What is the first test you would like to order here?
Okay, so definitely this patient is a patient of CNS infection and already on ventilator, and there is polyuria. First, we have to see whether what is the sodium status of the patient. So it is very high. Sodium is high, and urinary osmolality is low. So definitely it is meeting the criteria of DI. And since we have already the diagnosis central means CNS infection, we would definitely think about central DI. And post AVP response is also there. So it is central DI. And
what made the central DI develop out of nowhere in a child with encephalitis, sir?
Yes, yes. So it is central DI is common in all CNS infections. But here there's
also clinical deterioration. The GCS has become E1, M1, V1, which was previously responding.
Okay, okay. So brain death may be one of the cause, but otherwise also DI is quite common in this setting.
So if you have DI in a sick child, basically the main message is that the hypothalamic AVP neurons are very widespread. It means that a big area of your hypothalamus is gone. So if you have a sick child who suddenly worsens and develops diabetes insipidus, that's brain death. Generally, we talk about that. However, as very nicely said by Dr. Pradeep, that if you have infection, SIADH, salt wasting, and DI, all things can happen. But this scenario of a reasonably okay child suddenly becoming bad and pouring lots of urine, this is a form of a brain death DI. And in this case, do not give too much of vasopressin. Better is to give them fluid management will be better.
I'd like to invite sir again for the acute management of hypernatremia.
So now if we talk about the acute management of hypernatremia, again, it will depend upon what is the duration. So you want to correct it over at least 48 hours. Don't be in a hurry. Start maintenance fluid at the usual 4-to-1 equation. Then add free water deficit and ongoing loss. This is what you want to look at. The target fall is 9 to 12 millimole per liter. Do not want a dramatic fall in sodium because that can cause problem. In chronic cases, you can have a fall of around 6 to 9 because too rapid rise is bad in hyponatremia. Too rapid fall is bad in hypernatremia as well. The protocol is you typically give sodium of 70 to 100. 120% maintenance, you will usually get the trick. Monitor very closely for sodium 4-hourly. GCS status, you expect seizures to happen. Always have 3% saline ready. If you have a sudden decline in sodium and seizure happens, give a 3% saline. Similarly, if you are treating hyponatremia and the child becomes unwell, that is pontine mineralolysis is happening, give them free water. So that's the opposite. Both of these things should be ready in that perspective. So hypernatremic dehydration, you look at the fluid deficit, free water deficit, isotonic dehydration, how much maintenance is to be given, and correction and you will get a clue about what sort of fluid you want to give. In that regard, always be ready for seizures which may happen in that regard. And there are equations you can get this from the various parts, and you can get how much sodium and how much fluid is given. If you give N/2 and above over a 48 hours, you are okay from that regards. Finally, about hypokalemia. Hypokalemia can be because of cellular shift. All the potassium is going into the cell because of the insulin or other factors, or you are losing extra renal. In these scenarios, your potassium in the urine will be less than 20. You may have urinary loss where your urinary potassium is high. This could be either RAS dependent with hypertension because of hyperaldosteronism, Liddle syndrome, 11 hydroxylase or 17 hydroxylase, or you can have a problem of RAS independent cause like tubulopathy or RTA. Tubulopathy, you will have alkalosis. RTA, you will have acidosis. So looking at the volume status, looking at the blood pressure, looking at your pH status, you will know which way you are going for in terms of these problems and the scenarios. So clearly, if you have a volume, which is very, very important, you expect hypovolemia. If you have hypervolemia with hypokalemia, this is RAS excess. Urinary chloride and pH are very important. Everybody with hypokalemia should have alkalosis. If you have hypokalemia with acidosis, you have RTA or diarrhea. And again, magnesium is very important. We all say refractory hypocalcemia, get a magnesium done. But if you have refractory hypokalemia, there also magnesium becomes important in that regards. And then, of course, you can have a look at the blood pressure also, which will give you a clue. So any patient with chronic hyponatremia, exclude diarrhea, diuretic use or malnutrition. Blood gas, if it shows acidosis, do a urinary anion gap. If it is positive, it is renal tubular acidosis. Negative is GI loss. If you have alkalosis, this is a more common phenomena, and you have hypertension, you look at urinary calcium to identify Bartter syndrome. And if you have low urinary calcium, it is Gentleman syndrome. Hypertension with hypokalemic alkalosis is high aldosterone. And if aldosterone is high, it is hyperaldosteronism or CAH variant, or you have rarer causes. So mostly you will be seeing hypokalemia with acidosis, RTA versus GI loss, or this hypomagnesemia, which will be an important parameter to look at. So looking at basic things, you will make a diagnosis. So over to you, Dhwani.
Thank you, sir. We have a 2-month-old boy with hypokalemia in the setting of metabolic acidosis with a normal anion gap. How do we differentiate between diarrhea and RTA, Dr. Jyoti ma'am?
So 2-month-old boy with metabolic acidosis with normal anion gap, there are two main differential. One is GI loss and second is RTA. Now we'll see for the urinary. Yes.
Yeah. Okay. So urinary electrolytes.
Now we'll see for the urinary anion gap. If it's less than -20, it's GI loss. If it is more, if it is +20, it will be RTA.
So as we can see here that the sodium and potassium levels, even if combined, are less than the chloride level. So this is a negative.
It will come negative. So this is the case of diarrhea.
Very well pointed out, ma'am. So if you normal anion gap metabolic acidosis with hypokalemia, the two major differentials are RTA and diarrhea. To differentiate between the two, because both these conditions can present with the child having actual diarrhea. So to differentiate between the two, look at the urine anion gap, and if it is negative, you think of a GI loss, and if it's positive, you think of a renal tubular acidosis. Moving on, we have a 3-month-old girl with failure to thrive with hypokalemia, had a birth weight of 2,800 grams, and now at 3 months has gained only 700 grams. Contrary to the previous case, this child has a metabolic alkalosis in the setting of hypokalemia with BPs on the low normal side. So my question is to Dr. Nitin sir, how do we go forward in this case?
So the case is showing that the baby has failure to thrive, hypokalemia, alkalosis, and BP normal or little normal to low.
Yes.
So we will proceed with the two diagnoses, either Bartter or Zitterman. For that, you will do urinary calcium. And if it is high, then and the diagnosis will be Bartter if it is high. And in the low, the baby age is very low. So barter is more common.
Thank you, sir. So
Okay.
again, hypokalemia with metabolic acidosis, you think of a mineralocorticoid action excess probably. But in that setting, your BP should have been normal or high. Now that you see BP is on the low normal side, you think of, as sir has pointed out, Barter and Gentleman here. And to differentiate between the two, your urine calcium levels will guide you. Nephrocalcinosis is a surrogate marker of high urinary calcium levels, and this was a child with Barter syndrome. Next, we have an 8-year-old boy with early puberty, height of 134 centimeters, which is advanced for an 8-year-old boy. Had a pubic hair stage 4, which is quite advanced. The blood gas analysis revealed hypokalemic metabolic alkalosis with urine chloride of 100 millimoles per liter and BP on the higher side for an 8-year-old child. So my question is to Dr. Tarun. What differentials are you thinking of, and what would you like to look for on clinical examination in this child?
So, as evident from the scenario, it is a precocious puberty with metabolic alkalosis, with hypokalemia, with hypertension. So, I would like to look into two differentials like Rast effect or some steroidogenic hormonal defects like DOC or 11-DOC. And in this child, the cryptorchidism is there. So,
So
probably
if we go by the pathway, it says that if your blood gas shows alkalosis and your blood pressure is high, you look at the aldosterone level. But we have a high BP, which is a surrogate marker that aldosterone level is
aldosterone
high.
levels are high. So,
You've got undescended testis and yet precocious puberty.
precocious puberty.
So that means testosterone is not coming from the testis. It is coming from some other organ. That would be the adrenals. So this is not actually a XY individual. This is
This
an
is
XXS
XX.
individual with severe virilization, as you were suggesting, on 11-hydroxylase deficiency. So XX with adrenal producing a lot of DOC causing hypertension, hypokalemia, and then we also have a DSD in that regards.